Good morning, everyone. My topic for today's presentation is rate of IOL decentration in manual small incision cataract surgery and their visual outcomes performed by fellows. There is a continuous need to provide more cataract surgical services in developing countries. Ophthalmology residency programs play a very important role in training the surgeons. Various studies have shown an inverse relation between the number of surgeries performed by a resident and adverse surgical outcomes. So there is a need to understand the relation between resident surgical experience and adverse surgical outcomes in manual small incision cataract surgery. The aim of this study is to analyze the rate of IOL decentration in manual small incision cataract surgery and their visual outcomes performed by fellows. This is a retrospective cohort study performed from May 2022 to May 2023 at a tertiary eye hospital. Resurgeries performed for index manual small incision cataract surgery by fellows based on experience were evaluated and categorized into 4 groups. Seniors, that is those who have a surgical experience of more than 1 year. Juniors with a surgical experience of less than 1 year. Those who have a prior surgical experience of having performed less than 100 SICS and more than 100 SICS. And these groups were analyzed using computerized database. The resurgeries done within 30 days of surgery were captured and analyzed. Coming to results, a total of 3,957 SICS performed by 12 fellows were evaluated. The overall resurgery rate was 1.16%. We have seen a resurgery rate of 0.93% among seniors and 2.17% among juniors. So there was a statistically significant difference between seniors and juniors. And in those who had a surgical experience of less than 100 surgeries, the resurgery rate was 1.29%, and those who have performed more than 100, those who have a prior surgical experience of more than 100, the resurgery rate was 2.19%, and there was no significant difference between these two groups. We have seen that the most IOL decentration was the third most common resurgery that was performed, which accounted for 24%. And to our interest, we have even seen a greater percentage contributed by AC wash and cortical cleanup. Out of the total IOL redialings done, 86.9% had a post-op visual acuity of 6/12 or better, and 13.04% had 6/18 or worse. SICS is the most commonly performed cataract surgery in developing countries. It is less expensive than phacoemulsification and delivers comparable outcomes. Haripriya et al. Shows a resurgery rate of 1.17%, which is similar to our study. Schmidt et al. And other studies, they have shown 0.85% and 1.9%. Their studies were based on phaco. Even our study shows similar rates in SICS done by fellows. Haripriya et al. Shows a declining trend with increasing surgical experience. There is lower rates after performing more than 200 surgeries. Similarly, our study shows higher rates in juniors than seniors, but there was no significant difference between those who had a prior surgical experience of performing less than 100 and more than 100. Probably this can be due to assignment of least complicated cases segregated pre-operatively to the inexperienced surgeons and continuous supervision by senior surgeons. Haripriya et al. Shows a cortical cleanup and IOL redialing as the most common resurgeries done. In our study, the most common was AC wash, followed by cortical cleanup, and IOL redialing was the third most common. Wound reformation was the most common resurgery seen among juniors, probably due to improper wound construction. Cortical cleanup, most common resurgeries among the seniors, probably due to assignment of complicated cases like small pupil PXF and mature cataracts. Finally, to conclude, manual small incision cataract surgery is a safer technique for early and inexperienced surgeons in a developing country. Resurgery rates show a declining trend with experience among the training surgeons, even in complicated cases. The limitation of this study, the total number of complicated cases during this period that were performed by fellows were not analyzed.
So
Thank you.
Okay, thank you. Why is there an IOL decentration? The reason for IOL to be decentered?
In our study,
And I'm not saying study group. When do we get IOL decentration?
ma'am, pre-op factors probably due to pre-op zonular weakness or dehiscence.
Okay, leave the
Then
pre-op intraoperatively.
Intraoperatively, it can be because of iatrogenic complications like PC rent, especially the equatorial PCRs or something.
Okay,
Then iatrogenic zonular dehiscence. Then large rexes wherein one can be in the back. It is difficult to assess where
so
it
one
is.
haptic in the
One
bag and
bag,
other
one
in the
sulcus.
sulcus when you place.
And maybe the might be during the surgery the pupil might become small, and then becomes difficult for the inexperienced surgeons in the initial phases to assess correctly where the IOL is exactly. Sir?
Now, which lens did you use? Rigid PMMA lens or?
So, both, ma'am. Both, ma'am. Depending on the surgeon, they have chosen for themselves. Yes, rigid is more. Yes, sir. Yes. Thank you, sir.